Hi there, airway adventurers. Welcome back to my channel, that is NAV Talks. Today we are tackling a topic that is as easy as a P, that is the laryngeal mask airway, or commonly we call it as LMA. Now, here a question arises, that is, what's an LMA actually is? Yes, exactly, this is what I was expecting. Now, see, imagine the LMA as a little airway helper. It's like a teeny flexible tube that we put into a patient's throat to help them to breathe when they can't do it on their own. Now, you guys can see in this picture of an ideal LMA. You can see in this picture. This is the LMA, that is a laryngeal mask airway. You can see this is like a balloon with a straw. You can see, you can imagine this as a balloon with a straw, and this straw is connected to a pipe wire like structure to inflate this balloon, and this pipe is connected to the circuit to to manage the patient's airway. You can see how it is inserted. Now, before moving on to the airway topic, that is laryngeal mask airway, did you know LMAs were invented after a doctor got frustrated with traditional intubation method? Did you know that? Anyone? Yes, that is the story behind the invention of LMA. LMAs are invented by Dr. Archie Brain, the scientist name, that is Archie Brain. Dr. Brain, armed with his newly developed LMA prototype, he confidently inserted that into a patient's throat, demonstrating its efficacy to a group of skeptical colleagues. The patient breathes comfortably, and Dr. Arki Brain and colleagues are amazed by the simplicity and effectiveness of the device. Over the years, LMA underwent further refinement and improvement. Different sizes and variations were developed to suit various patient population and clinical needs. This is the story behind what happened. Dr. Arki Brain got frustrated because during that time they had only a little amount of airway management devices. So what he experimented by using this LMA prototype on a patient with his colleagues. After the successful surgery, the patient breath had taken a normal breath, and the patient saturation was normal. So, like this only, this LMA started innovating. But over the years, what happened? The LMA got new variations like refinement and improvement. Now we have a lot of different, like we have different sizes of LMAs, where, and we have a, different type of variations also in LMA. So this is the story behind how LMA got invented by Dr. Arki Brain. LMAs are invented by the person, the scientist, that is Dr. Arki Brain, after he got frustrated with traditional intubation method. So this is the story, a small and simple story. What is the use of airway? They'll manage the patient's airway, like they'll help the patient to breathe when the patient can't breathe on his own. During that time we will use LMAs. So now we will move on to the topic, that is supraglottic airway devices. As the name suggests, they are placed above the glottis. These LMAs are also called as supraglottic airway devices. Why they are called supraglottic airway devices? Because as the name suggests, supra means above, glottis is glottis. So they are placed above the glottis, means in the laryngeal inlet. That this should be, this cup should show should be in the oropharynx, should be in the oropharynx. Now you can see this picture. This is the picture of an ideal LMA. You can see in this picture. So these are the equipments or devices placed above the glottis. They are placed above the glottis. These are commonly used for airway management. They are commonly used for airway management. Why they what is the use of using LMA? It is to manage the airway. If the patient can't breathe on his own, during that time we will insert LMA and will maintain the patient's airway. The most commonly used supraglottic airway is LMA, that only. Supraglottic airway is nothing but LMA only. Next, in LMA, LMA means laryngeal mask airways. Laryngeal mask airways. So, before moving on to the laryngeal mask airways, see, you can see this picture. This is the ideal LMA picture showing all the parts of the LMA. You can see this picture. This is the cuff. This is the cuff. You can see this picture. This part. This is the cuff, and it is inflatable also. It's like a balloon. It's like a balloon. See, this is inflation pilot balloon. If we insert inject some air, this will this will fill. This will become fill, and it holds the structure. It holds the structure tightly. Like it is like it holds the structure. And here you have aperture bars. You can see this one. This whole like structure. These are the aperture bars. What is the use of aperture bars? These aperture bars are also called as ventilation ports. These aperture bars are also called as ventilation ports. So next we have a tube like structure. A tube like structure, that is connector, which is connected to the circuit, and the circuit is finally connected to the machine end, that is anesthesia machine. Next is inflation line. See, this is the inflation line. So through this they'll inject air and they'll fill this. Before the procedure also we have to do this, because to check whether the inflation the cuff is where there is any in the cuff, whether there is any leakage or what, we have to check that. And in the after intubating with LMA, that time also we will inflate the cuff, and after inflating we will check the air entry. So this is the structure of an ideal LMA, showing their parts also. Next, we will move on to the topic, that is laryngeal mask area. As you all know, these are again classified as first generation and second generation. LMAs are again classified as first generation and second generation. Why they are called first generation? Because during that time, that the person, that the scientist or Archie brain invented a simple prototype of LMA, a simple LMA prototype. So that is the first generation LMA. That is the those are the first generation LMAs. So these are invented by Dr. Archie brain. So that's why they are also called as brain masks also. These are also called as brain masks. What is the position of the this one LMA? Where we will insert this one? Where we will insert this one? We will insert this one, that the position of this tube will be in the oropharynx. You can see this picture, this word oropharynx. They are placed in the oropharyngeal region. Oropharynx. And the inflated cuff, after inflating with this, like we will inject some air into this, and after inflating this will become tight. This will become tight, and what it does, it will seal the lateral and posterior pharyngeal walls. What this will do, this will seal the lateral and posterior pharyngeal wall. Now think, like I'm just like imagine. See, this is the pharynx, huh? So if it is the if this is the pharynx, what are the parts? This side will be lateral part, these two will be lateral, and this will be posterior. So this cuff will seal the lateral and posterior pharyngeal walls. It will seal the lateral and posterior pharyngeal wall. And where is the position? Exactly, it's in oropharynx. It will be in oropharynx. This is the first generation LMA. These are the first generation LMA. Why they are first generation LMA? Because they are the prototype of LMAs. Because they are invented by Archibrain. They are the prototypes. First prototype. Next, we will move on to the advantages of LMA. Sorry, disadvantages of LMA. What are the disadvantages of LMA? You can see there will be increased risk of aspiration. There will be increased risk of aspiration will be more. Aspiration will be more when we insert LMAs na. So see, first, why they invented second generation LMA? Because first generation LMAs were like we have a limitations in that na. We had some limitation, like we have now also. If we use first generation LMA, there will be some limitations. So that only we call it as research. After researching, like after so many years, what happened, they made unlike they added some more features in that LMA. So before that, they didn't know about these things na. So those were the prototypes of LMA. So there was a lot of aspiration. The risk of aspiration was more with the first generation LMA, and they can cause laryngospasm and airway obstruction if displaces anteriorly. If we insert them anteriorly, like what is the position of the LMA? It will be in the lateral and posterior pharyngeal wall. If we displace anteriorly, what will happen? Airway obstruction will be there, na. So it should not obstruct the airway. It should not obstruct the airway, and it caused laryngospasm also. What it caused? Laryngospasm. Laryngospasm. There was a risk of aspiration. It caused laryngospasm and airway obstruction. Airway obstruction is due to if we insert the LMA in the anterior portion, more anteriorly. During that time, airway will obstruct. Obviously, airway will obstruct. So during that time, there might be a airway obstruction also. Like if there will be a complication. If the airway is not, the patient is not maintaining his airway patency, then what is the use of placing this LMA? No, nothing na. So that is the disadvantage. Next, trauma to oral cavity. Trauma to, while inserting LMA, what will happen? If there is any injury, if that is very, like if we do harsh intubation with LMA, it will cause trauma to oral cavity, and sore throat. Sore throat will be there. These are the disadvantages of first generation LMA. First generation LMA disadvantages are there was a more risk of aspiration and laryngospasm, airway obstruction if we place the LMA in anterior portion more, and trauma to oral cavity, sore throat. So next we when it comes to the contraindication means in which condition we have to avoid these LMAs. In which condition we have to avoid these LMAs? One is full stomach patient. Full stomach patient. Why full stomach patient? Because there will be a more risk of aspiration, as you saw in disadvantages. Full stomach patient will have like more prone to aspiration. So during that time also we have to avoid using LMA. In full stomach patient, we have to avoid LMAs. In hiatus hernia, pregnancy, chances of aspiration will be high. Like full stomach patient also, in pregnancy and hiatus hernia, there will be a more risk of aspiration. Aspiration will be more. So that reason, in that condition also, we have to avoid LMA. In which what all condition we have to avoid? In full stomach patient, hiatus hernia, and pregnancy. Why we have to avoid? Because there will be a more chances of aspiration. There will be a chances of aspiration. Next is oropharyngeal edema, or oropharyngeal abscess or mass. As we saw in previous slide, where is the position of LMA? It's in oropharynx. It's in oropharynx. So if there is any mass on that structure, what it will happen? It will obstruct the airway. So like we can't process that, we can't insert that LME na. It will cause complications also if there is any mass or abscess. So in that condition also we have to contraindicate using LMA. So what are the disadvantages of LMA? Increased risk of aspiration, laryngoscopasm, airway obstruction if we displace the like if LMA is placed in anterior portion more, and trauma to oral cavity, sore throat during that time. Like in that situation, these are the disadvantages of using LMA. When it comes to contraindications, contraindication in which condition we have to avoid LMAs, using LMAs, that is full stomach patient, pregnancy, hiatus hernia. Why we have to avoid? Because there will be a risk of aspiration. Aspiration will be high, and it is, and that next one is oropharyngeal abscess or mass. These are the disadvantages and contraindications of LMA, that is first generation LMA. but but when it comes to the second generation LMA, what they did, they made like some extra features, they added some extra features to reduce this to reduce these things, that is aspiration, to reduce the complication of aspiration. Aspiration was more in first generation LMA, but in this they made some, like they made some extra features. What that extra feature did, there it reduced risk of aspiration, though these LMAs reduced the risk of aspiration. So that is the difference between first generation and second generation. Next, in that second generation, we have a lot of types in second generation LMA according to their structure and the features in it. See, first one is intubating LMA. You can see in this picture, as you can see, this is the intubating LMA. Why they are called as intubating LMA? Because during intubation, it will be helpful. It is, it will be helpful. Why it will be helpful? Because we can insert up to, we can guide up to 8 number endotracheal tube through it. We can guide up to 8 number ET tube in with or through it, through LMA. That is the intubating LMA. Intubating LMA, as the name suggests, they are guided to like they are like endotracheal tubes can be guided through it. Which how, like how much number? That is now up to 8 number. Up to 8 number. Next, we will move on to the second type. That is proxial LMA. You can see this picture. This figure you can see. See, what is the extra feature what they added? They added a drain tube here. You can see here. What they did? They added the extra tube here. What is the use of this one? It will deflate the stomach. What is the use of this? It will deflate the stomach. They made extra tube, and that is called as drain tube. That is called as drain tube. What is the use of this one? This will deflate the cuff. Sorry, stomach. It will deflate the stomach. Then next, what is the difference? Next one. What is the next difference? You can see this, the cuff is very large. The cuff is very large. Cuff is very large, and it has a like larger and posterior cuff also. It is a very large cuff. It's very large cuff, and that is proxial LMA. What are the features of proxial LMA? Extra features. They are, they made drain tube in it. What is the use of drain tube? It will deflate the stomach. It is used to deflate the stomach. And what is the next feature? That is they made a large cuff. They made a large cuff. And next we will shift to the third part. That is third type. That is supreme LMA. Supreme LMA. See what you can see, like you can spot the difference here also. So what they did, they just added the part. What is that part? That is patient bite. Patient bite. That is the patient bite. What is the use of the patient this bite? That is also called it as bite block also. We can call it as bite block. Why that is called as bite block? because if the patient bites also, if the patient bites also, the tube will not get damaged. The tube will not get damaged. So that is what like they made. That is how they made the portion, that is bite block portion. It's like a same like Prozel LMA only. But what is the extra feature? They added a bite block portion here. What is the use of bite block portion? It it will not damage if the patient bites also. It will not get damaged. So that is the supreme LMA. Supreme LMA. Supreme LMA. What are the features of supreme LMA? That is the extra feature is like it's like same like Prozel LMA, but they made some bite block portion in that tube. What is the use of that tube? If the patient bites also, the tube will not get damaged. The tube will not get damaged. That is the use of supreme LMA. Next we will move to the fourth type, that is eye gel. Eye gel. You can see the like the name of the tube only. Gel. It's like a gel only. The tube will be pre-filled with gel. This tube will be pre-filled, already filled with gel. What is the use of this gel? It will avoid this gel will avoid the complications of air-filled cuff. Sometimes air-filled cuff will be there, na? So it will avoid the complications of air-filled cuff and leakage also. If the air cuff filled will be there, there will be complication. If the tube is leaked, if there is any leakage in the tube, that is also complication. So and so this is the igel LMA. You can see this figure. Here in this we have a lot of types also, like sizes will be there. I'll show you next slide, like what are the sizes of LMAs. Next, it also has a drain tube to deflate the stomach, but in this picture it's not available. But it also has a drain tube like this only, like this only. It also has drain tube, but in some hospital they use only this one for regular use. For regular use, they'll use only this one. Igel only they'll use. Igel with drain tube they'll not use most commonly, but most commonly what they use, only this one, only this one they'll use. Next fifth type is, that is LMA seat track. LMA seat track. You can see this figure. If you see the figure also, figure only, you'll get to know what is the difference here. That is, you can see it has a screen. It has a screen in it to visualize the structure. What is the use of this screen? It will visualize the structure, like which part we are in, like in which part we are going and all. So these are the types of second generation LMA. What are the types? Those are, first one is intubating LMA. Intubating LMA. What is the use of intubating LMA? Eight up to 8 number endotracheal tube can be guided through it. Huh? Up to 8 number endotracheal tube can be guided through it. Next one is Prozel LMA. What is the use of Prozel LMA? They made a extra tube to deflate the stomach. That tube is called as drain tube. And this Prozel LMA has larger cuff. It has a larger cuff. And when it comes to Supreme LMA, what is the extra feature added? There is a bite block portion. If the patient bites also, the tube will not get damaged. That is the feature of the Supreme LMA. Next is eye gel. As the name suggests, it is pre-filled with gel. It is pre-filled with gel and it will avoid the complication such as leakage, damage and puncture also. And it also has a drain tube, but most commonly they use only simple LMA, simple eye gel. Simple eye gel they will use. Next is LMSC track. As the name suggests, LMSC track. There will be a monitor here, and it will guide. It will guide to visualize the structure. It will be helpful. We can see the visual, like uh, what are the structures we are in, like in which structure we are in, and all we can see that easily. That is the LMA C track. Next is indications. Indications mean in which condition we will use these LMAs. In which condition we will use LMAs. In which condition? In as a alternative to intubation. As a alternative to intubation, where difficult intubation is anticipated. See, if there is any difficult intubation is going to happen, if the patient is in operation theater, and we can see the his condition, so we can easily identify he is very like there we can see the difference. And if there is any difficulty when intubation is going to happen, we can suddenly we can change that into a intubation with LMA. It is like an alternative method. It's like an alternative method. Instead of using ET tube, we'll use LMA in that condition. Instead of ET tube, we will use LMA in that condition. Next one is emergency situations where intubation and mask ventilation is impossible. Sometimes what happen in emergency situation, while intubating with ET tube, there will be chance like more chances of, not more, like there will be some chances of complications. Nah? If there is any complications, what will happen? Patient will go into hypoxia, patient will go into apnea. So what happens? Patient saturation will come down. So we have to maintain the patient saturation. Nah? We can't wait. Yeah, if the patient ventilation is, if we can't wait too much time, na. So during that time, instead of wasting time, we'll immediately what we have to do, we have to choose that LMA, and we have to insert that without wasting a single minute. So that in that condition also we can use LMA, where in emergency situation where intubation and mask ventilation is impossible. Intubation and mask ventilation is impossible. In that condition also we can use LMA. And next is an elective method for minor surgeries. An elective method for minor surgeries like gynae procedures, like sterilization will be there, or like how much it will take. It will take a maximum half an hour to 45 minutes maximum. So instead of inserting ET tube in that condition, we can easily insert LMA. Na? It is very small procedure. During that condition also, we can use LMA. These are the conditions. Next, we'll move on to the advantages. What are the advantages of LMAs? Why we'll use LMAs? Why? Because they are like what are the uses of LMA? What are the uses of LMA? Why we will use LMA? They are easy to insert, as I also did already said in emergency, na? Without wasting a time, we'll insert this tube, the LMAs. So they're very easy to insert. No need of any like, if the unknown person is also there, he can easily insert that. And it does not require any laryngoscope and muscle relaxant. It does not require any laryngoscope and muscle relaxant. If there is no need of laryngoscope and muscle relaxant, what is the importance? Do comment your answers. If there is no requirement of laryngoscope and muscle relaxant, what is the use? What is the use? You just comment in the comment section. And does not require any specific position. They do not require any specific position. There is no requirement of position, but in some conditions they may require some little bit head lift chin head tilt chin lift. Will some in some condition it requires, but not in all the condition. Sometimes we require head tilt chin lift, head lift, head tilt chin lift. That is the like position of the patient. Like easily we can insert that. So to remember this one, it is written here as does not require any specific position, but sometimes some in some condition it requires some position also. What is the position? That is head tilt, chin lift. So to remember that easily, you can remember this one also. That is McDonald placed an LMA, E-A-E-A-O, with a tilt here and a lift there. You can read this one. If you remember this one, it's very easy. That is head tilt and chin lift. Head tilt, chin lift. That is, I'll repeat that again. McDonald placed an LMA, E-A-E-A-O, with a tilt here and a lift there. Tilt here means we have to tilt the head, and lift chin. We have to lift the chin. That the position of LMA. It does not require, actually it does not require any specific position, but in some condition we require that position also. So next, what is the advantages? What is the advantages of LMA? That is sympathetic stimulation will be very less. Sympathetic stimulation will be very less. If there is less sympathetic stimulation, there is no requirement of, like, if there is no, like, if we are not using any laryngoscope, there will be not like, there will not be any laryngoscopy reflex will not be there. Na? Sympathetic stimulation is caused due to laryngoscopy. So if we are not using any laryngoscopy, then there will not be like sympathetic stimulation. So that is the advantages. There will be less sympathetic stimulation. Sympathetic stimulation is very less. Next is patient awakening is very smooth. It requires very less muscle relaxant. It requires very less muscle relaxant. So in the because of that, patient awakening will be very smooth. Patient awakening will be very smooth, and they are reusable also. We can use those LMA on different patients after sterilizing them, after doing ETO of LMAs, after sterilization of or after disinfection, we can use those LMAs on different patients. Next, we will move on to the sizes of LMA. See, sizes of LMA will be based on weight of the patient. They are how we will choose the LMA for that particular patient, according to his weight or according to her weight. We will choose. So first number LMA will be up to 5 kg patient, for 5 kg patient, and 1.5 for 5 to 10 kg patient. 5 to 10 kg, and 2 number LMA for 10 to 20 kg patient. If the patient is between 10 to 20 kg, then we will use 2 number LMA. If the patient is if the patient is 20 to 30 kg, what size of LMA we will use? We will use 2.5 number. We will use 2.5 number. Next, if the patient is between 30 to 50 kg, if you consider a patient is standing and his weight is between 30 to 50 kg, how like which number LMA will use? We'll use 3 number LMA. And if the patient is 50 to 70 kg, we will use 4 number. And if the patient is between 70 to 100, that is greater than 70, between 70 to 100, we will use 5 number LMA. That is for large adult. We will use large for large adult. So these are the sizes according to the patient's body weight. According to the patient body weight, we will choose the appropriate size for that patient. So these are the sizes of LMA. So next we will move on to the technique, like insertion technique. How we will insert this LMA? How we will insert this LMA? It's very easy. What we have to do first, the first thing should be prepare the equipment. Before doing this procedure, we have to prepare the equipment. Otherwise, what will happen in the after this? If we give some drugs, sedating drugs, we can't roam here and there to find out those things. So before only we have to gather all the things. What we have to do? We have to choose appropriate size for the particular patients. According to the patient's weight, we have to choose appropriate size. And lubricant. What is the use of lubricant? It will It will prevent the like trauma, if there is any trauma, like prevent from trauma to oral structures. And syringe, for what is the use of syringe? To inflate the curve or to deflate the curve. And next is patient position. What is the patient position? Patient will be in neutral position only. Neutral position means in supine position only. But during intubation sometimes we require head tilt, chin lift. Next is clear the airway secretions. What is the next thing? We have to like that airway should be clear from secretions. It should not there should not be any secretions in the airway. If there is any secretion in the airway, there will be a more difficult intubation. Next is prepare the LMA, apply the lubricant. This is a pre-preparation before intubation. We have to do these things. Next, in intubation what we have to do? We have to apply the lubricant. As already said, we have to like you saw na, lubricants. We have to apply the lubricant on the LMA. After applying LMA lubricant on the LMA, we'll insert the LMA in the patient's throat. There is a position of the tube. It will be in the oropharynx. It will be in the oropharynx. Next, we have to inflate the cuff. Once we inflate the cuff, what it will do? It will seal lateral and posterior pharyngeal wall. What is after inflating the cuff? What is the next step we have to do? Is to verify the placement, whether the tube is in correct position or not, by auscultating. Next is secure LMA. Next is to secure the LMA. We have to fix the LMA. After fixation, what we have to do? We have to connect that LMA to the ventilation, that is to the circuit, and circuit to the machine end. This is the step. Next, after ventilation, what we have to do? We have to monitor the patient until case gets over. We have to monitor the patient until case gets over. This is the LMA technique. So before ending this session, how to insert a laryngeal mask airway? How we will insert? I'll just give a overview. So what they are doing? They're deflating and they're applying lubricant and they'll just insert it. They just insert it. And next is to connect to the ventilation. To connect to the ventilation and inflate that cup. After that, we have to auscultate the patient. That is the end of the procedure. And we have to monitor the patient until case gets over. This is how the procedure is. That is the technique of inserting an LMA. Inserting a LMA. So, guys, let's wrap up this. And that's a wrap. Now, LMAs may seem fancy, but they are really just little helpers, making big differences in airway management. Thanks for joining with me today, and until next time, stay curious and keep shining. Thank you so much.